Lisa and I are pleased you all are here today. I am Liz Mazzell, the co-chair, along with Lisa of the research work group for Annie. And I just some information before we get started. Like Lisa said, we are recording and it will be available later so you can watch again. And also, if you signed up to attend today, you can get CE credits. So you look out for that email so you can complete the post test and complete the evaluation as well. So you have to get 80% or above to get the CE credits. And get these last two. I am very excited to introduce Dr. Charlene McNeil. So she has held many hats, including she recently was the director where I work at East Carolina College of Nursing. She was the director of the PhD program, and now she is the Associate Dean of Academic Affairs at the Fran and Earl Ziegler College of Nursing at the University of Oklahoma, and that's in Oklahoma City, Oklahoma. She is also a veteran, so always want to make sure I let people know about that. And today she's going to speak specifically about emergency preparedness, the response of nurses and individuals in the community, particularly what we need to know about vulnerable populations. And she will also discuss the evolution of her research, and she'll describe findings from several of her studies, including implications for practice, as some resources for nurses. So take it away, Dr. McNeil.
Hi, first of all, thank you. I'm honored that you would take time out of your day to come and listen to what I have to say. This is a topic that's very near and dear to my heart, because I think too many times when nurses don't have a seat at the table and we talk about emergency preparedness and response, we have more of an avenue to really make a difference, particularly among vulnerable populations, than some of the boots on the ground solely response organizations. We have an avenue to talk to people and let them know what they need to do to prepare for a disaster, inclusive of their diseases. And the research that I've done and others have done shows that people who are vulnerable and have chronic diseases are 3 to 4 times more likely to be prepared for a disaster if a healthcare professional has taken the time to talk to them. Yet when I look around, nurses are not always included in the planning. And I find it very interesting, because we do have a very unique and important contribution to give that truly has an impact on health outcomes after a disaster and could lighten the load on emergency responders through preparation and mitigation. But more on that. So the title of my talk is The Impact of Healthcare Providers on Emergency Preparedness and Response. The objectives. At the end of the presentation, you should be able to describe the disaster continuum and your role in it. Evaluate your own emergency preparedness, both personally and professionally. And it is important to note it is very different to be prepared personally and professionally, but we'll talk about that more later. You'll be able to discuss the impact that nurses have on emergency preparedness of vulnerable population, and you'll know how to find emergency preparedness education. We are not going to be able to teach you how everything you need to know in the space of this presentation. So I thought it would be more valuable to provide you with resources so that you could study on your own later on, once you figure out where your weaknesses might be in terms of emergency preparedness and response knowledge. As a little bit of a background, we all know disasters are really bad. They've happened a whole lot. A lot of people get impacted, but sometimes it's a bit sobering to really look at the numbers. And so since 2010, there have been more than 250 disasters in the United States, impacting over 88 million people. National health security is a state in which the nation and its people are prepared for, protected from, and resilient in the face of incidents with health consequences. Threats and risks to national health security range from infectious diseases, terrorism, inclement weather, and nuclear accidents. And believe it or not, we do have some of the most in need of attention nuclear infrastructure. So that is also a real threat in areas where there are nuclear power plants, such as Arkansas, which is not too far from me. To facilitate the best possible outcomes in the event of a disaster, individuals have to engage in preparedness activities in their homes and their communities, and really anywhere you frequent. So if you are at work a lot, you need to make sure that you keep in mind that you spend a lot of time there and you should be prepared there. If you look at California, they're actually, particularly government employees, are required to have emergency kits in their offices, in addition to in their homes and in their cars. And that's because they spend so much time there. But theoretically, as the level of preparedness increases, the vulnerability of the community and the individual level also decreases, because they're built upon one another. You have more resilient people, that leads to more resilient communities. So a little bit about the disaster continuum. There are actually 4 phases in the disaster continuum, and that includes preparedness, response, recovery, and mitigation. We refer to this as a continuum or a cycle because it's continuous, and one phase can blend into another without a clear ending or a beginning. And there are other components that are involved or touch the disaster continuum. They're also important, so I'm including those here as well. Just so that you have some context and some information on which to really understand what I'm talking about as we consider emergency preparedness and response and the nurse's role in it, there are a few important definitions that I want to include to provide a basis for better learning. When we're talking about emergency preparedness, we are talking about the steps that you take to make sure that you're safe before, during, and after an emergency or a natural disaster. These plans are important for your safety in both natural disasters and man-made disasters. Disaster mitigation measures are those that eliminate or reduce the impacts and risks of hazard through proactive measures taken before an emergency or disaster occurs. Prevention is done to ensure that human action or natural phenomena do not result in disaster or emergency at all. If we could prevent all disasters, that would be great. It's not possible, but we can where we're able to. Primary prevention is to reduce, avert, or avoid the risk of an event occurring by getting rid of the hazard or the vulnerability. Response encompasses the decisions and actions taken to deal with the immediate effects of an emergency. In many scenarios, it's likely to be relatively short, and it can last for a matter of hours or days. Rapid implementation of arrangements for collaboration, coordination, and communication are vital. And the response is typically what people think of first in a disaster continuum. It's kind of like the biggest, it's the sexiest component of the disaster response continuum, and it gets the most attention. But the most effective at protecting human health are those things that we don't see, that happen long before the disaster occurs. And so they're equally important. Disaster recovery is an organization or person or family's method of regaining functionality after events like a natural disaster occurred. Things may look different after a disaster, and one might consider calling that the new norm. Post-disaster recovery planning is defined as developing a set of strategies to assist a community or a person in rebuilding after a disaster occurs. One conceptual model that I've used frequently in my research, because I like the simplicity of it, I like the way it breaks things down within the disaster continuum, is the Homeland Security Advisory Council's framework for the conceptual relationships among preparedness, resilience, and risk reduction. This conceptual framework provides a foundation for research on the constitutive elements, in particular preparedness. Key concepts include preparedness, resilience, and risk reduction. Preparedness in the U.S. This is abbreviated CRTF, but it's the Community Resiliency Task Force. But it's depicted in terms of preparedness at a national level and involves activities performed before, during, and after an event, which includes planning, organizing, equipping, training, and exercises to build and sustain capabilities necessary to prevent, protect against, mitigate the effects of, respond to, and recover from threats that pose the greatest risk to the security of the nation. Resilience is defined as the ability to resist, absorb, recover from, or successfully adapt to adversity or change in conditions. And so if you look before, during, and after a disaster, there are opportunities for nurses to really interject or participate in efforts to help people before, during, and after disaster in terms of preparedness. Before, they can protect, prevent, protect, and mitigate. During, we are integral in response. But after, we are also integral to recovery. So all three phases, we can exert our efforts and make a difference. In terms of resilience, we are also critical in helping people learn how to resist a disaster, absorb a disaster so that they can recover that much more quickly, and then also we can help recover or adapt. For prioritization, in terms of risk reduction, basically what we're doing is reducing the consequences from failure, either reducing the probability of failure or reducing the time to recovery after a disaster. So a little bit about my work here in disaster research. My work encompasses several phases of the disaster continuum. I began my research trajectory by studying how current emergency preparedness education impacted household and individual preparedness levels, realizing that there were no current emergency preparedness education that impacted household emergency preparedness level, or let me start again, realizing there were no current instruments to empirically measure preparedness and no literature on how nurses could prepare their clients who had increased medical needs. A lot of what we saw was expert opinion in places like ready.gov, and not to say that those places, those websites and those experts don't have knowledge to give, but as researchers know, it's better when you have empiric research and an assessment across all stakeholders on what emergency preparedness really looks like, and then you craft an instrument that is has established psychometrics and validity. And so that's what my colleagues, and a shout out to Tara Hegel, who's on this call, but that's what we set out to do. And so that Delphi study is now published in Disaster Medicine and Public Health Preparedness. And we have also piloted it a couple times, and those studies are either already in publication or being published right now, but we continue to further refine that instrument. And it is the only one of its kind that empirically measures emergency preparedness. Another thing that I look at is the impact of healthcare providers on preparedness. We looked at, another team of researchers and I looked at the Health and Retirement Survey, which is a national database. We did a secondary data analysis to determine whether preparedness education by healthcare providers improved preparedness among vulnerable populations. We found that preparedness increases threefold among those whose healthcare provider educated them about such measures. It is critical that people who are on vents, who have medications, who maybe have cognitive impairment or have access and function needs, know how to navigate before, during, and after disaster. And we make a huge difference in this. We found this incredibly important, so I began a subsequent study collecting data among older adults in Arkansas and had similar results also published that further underscore the importance of healthcare provider education before, during, and after a disaster. Another area of disaster research is related to the provision of care or medical resources after a disaster and the ability for healthcare systems to surge to meet the increased demand. I work very collaboratively. I embrace team science on a number of levels, working with people from industrial engineering, human environmental science, other nurse researchers, and several disciplines. We find one of my favorite terms is epistemic reflexivity. And if you know me, you know I love that term. And basically what that is when you have knowledge from different perspectives, it provides a much richer 360-degree view of a phenomenon. So it's like looking at a Coke can. If each one of us is standing around a circle looking at the same Coke can, we're going to have a different view and we can describe it from our view. But when we all collaborate on what our view of this Coca-Cola can, when we put all that together, it provides a more complete picture. So I said all that to say when I use team science with these other disciplines, we feel it provides a richer knowledge. So working with industrial engineers provided a really unique research group to look at home health agencies in Northwest Arkansas and how we might create routes that more expeditiously deliver medical countermeasures to homebound patients after disaster. We wanted to really sort of overcome or provide a way to overcome one of the bottlenecks in what we call the last mile of delivering medical countermeasures after disaster. And one of the bottlenecks is, no surprise, nursing. There's just not enough nurses anywhere, and that includes when we're delivering medical countermeasures in communities after disaster, what we call points of dispensation or points of distribution. So we looked at alternative means to distribute such countermeasures using home health agencies, and that was published in Disaster Medicine and Public Health Preparedness. And I was invited to speak as a part of a national panel in Washington, D.C. At the National Center for Disaster Medicine and Public Health in 2018 on this topic. At this moment in time, we are seeing the bottlenecking of the distribution of, of COVID, not so much vaccines at this point, but when the vaccines first came out, that was one of the bottlenecks. It's just having enough nurses to distribute it. But now we're seeing care limited by the number of nurses and nurses leaving the profession. I think we lost 100,000 nurses last year, according to the latest reports. And so that's going to limit our surge capacity. And so shout out to all the budding nurse researchers. That is going to be an area of emphasis, how this exodus of nurses from our profession is going to impact things like this, not just normal care, but with climate change and everything else, we're going to see emergencies again. And as I stated, nursing is critical in them. And so what is that going to look like moving forward when we have even fewer nurses in the profession? Other concepts important to nursing are the duty to care, nursing knowledge, nurses' role in a disaster, and I've published on all of these topics. I've also published 2 book chapters in a soon-to-be released book title that was delayed due to supply chain issues, like everything else. The supply chain issues impact everything. But the book is a book by Joanne Langen called Preparing Nurses for Disaster Management, A Global Approach. And that should be out, I want to say June of this year. You can find it on Amazon for pre-order. But both chapters that I wrote are global resources for nurses to obtain the knowledge they need to prepare themselves, their clients and patients, and their communities for disaster to facilitate positive health outcomes. The guidance provided in these book chapters is grounded in the International Council of Nurses Core Competencies in Disaster Nursing 2.0, which was released in 2019. In fact, I'm also honored to report that several of the authors of the ICN Core Competencies in Disaster Nursing are also authors within this book. COVID-19 presents an unprecedented opportunity for disaster researchers such as myself to study and find ways to improve healthcare response during critical times. For me, it provides the opportunity to test many of the concepts that I've already begun studying. It also has significant implications for preparedness measures. New projects include examining disaster shelter demands and logistics with the American Red Cross. I just had a study published on that, which I did not include in my previous description studies I've done. Analyzing changes in sheltering demand after COVID-19 and a NIH grant for seroprevalence with partners from seroprevalence of COVID from the University of Utah to the NSF. Since July 2020, I've been funded on 2 grants to assess the prevalence of COVID-19 among students and community at large, and the levels of antibodies of past positive participants and how they change over time, and how the pandemic has affected the lives of Eastern North Carolinians. And so I'll only just briefly just highlight a few publications here in recognition that FEMA, American Red Cross, and CDC recommendations for emergency preparedness are adhered to in varying ways by different groups. I attempted to learn more about the barriers and facilitators to becoming prepared for emergencies using a qualitative approach. In the article, Individual Emergency Preparedness Efforts, a Social Justice Perspective, we explored this with participants to learn that many lack the financial resources to purchase or infrastructure to store recommended items that we recommend that governments and non-governmental organizations derive methods of helping those with that are more vulnerable to disasters overcome these barriers. So what that would look like is, responses need to be equitable, not equal, because different populations need different amounts of resources. So just to say that families should purchase preparedness kits is not equitable when you consider the fact that every family does not necessarily have it. It costs about $500 for a family of 4 to purchase the full American Red Cross kit. And so you can imagine if there are families who don't have enough money to buy food or keep the lights on, they're not going to buy emergency preparedness items. And so equitable response might look like government subsidizing of those types of resources for vulnerable families, and then provide that to them, where if someone had the resources to buy those items, they would not need that kind of support. So in the article titled Characterization of Nurses' Duty to Care and Willingness to Report, we investigated nurses' perceived duty to care and whether there were differences in willingness to respond during events based on perceived duties, levels of duty to care. Analysis of willingness to report to work based on levels of perceived duty to care resulted in the emergence of 2 groups, a lower level of perceived duty to care group and a higher level of perceived duty to care group. The most discriminating characters differentiating the groups included a fear of abandonment by coworkers, reporting because it was morally the right thing to do, and because of imperatives within the nursing code of ethics. So in this article, we conclude that it is important for nurse management to develop strategies to advance nurses' safety, minimize nurse risk, and promote nurses' knowledge to confidently work during disaster situations. Also, again, with an industrial engineer, to learn ways to improve the distribution of medical countermeasures after a pandemic or other disasters. We did the study titled In-Home Strategic National Stockpile Dispensing by Means of Home Health Agencies and Alternative Means of Dispensing to Vulnerable Populations. The last article I'll highlight is the article titled Emergency Preparedness Competencies Among Nurses, Implications for Nurse Administrators. The aim of this study was to examine current levels of self-reported professional emergency preparedness competencies among nurses using an instrument that had been widely utilized by researchers in this field over the last 2 decades called EPIC, and that was out of the Wisconsin Nurses Association. The relationship between professional emergency, and we'll talk about, again, the difference between personal and professional emergency preparedness a little bit later, but this article dealt with the relationship between nurse professional emergency preparedness competence, personal preparation for a disaster, and perceived likelihood for reporting to work after a disaster. Our results indicate that significant weaknesses in nurse professional emergency preparedness competence existed, and over the last 15 years, they haven't improved. Additionally, we learned that there are positive correlations between the likelihood to report personal preparedness and professional emergency preparedness competence. We see the importance of competence and knowledge, preparedness and likelihood to report play out every single day since COVID first swept the globe. Nurses can be crucial assets in disaster risk reduction, or DRR, and they should be prepared to play an active role in all phases of disasters, including planning and decision making. To fully embrace this role, nurses must first become familiar with planning documents and framework used within their home countries, regions, states, territories, provinces, and local communities. For example, in the United States, public health nurses must use the National Response Framework to articulate and evaluate core capabilities designed to engage the whole community in efforts to achieve the national preparedness goal of a secure and resilient nation with the capabilities required across the whole community to prevent, protect against, mitigate, respond to, and recover from threats and hazards that pose the greatest risk. Additional valuable resources are available from the United States Department of Health and Human Resources Office of the Assistant Secretary for Preparedness and Response, or ASPR, through ASPR's Technical Resources Assistance Center and Information Exchange that is known as TRACY. The CDC outlines standards for preparedness and response capabilities for public health departments and offers multiple resources to promote effective emergency preparedness and response at the state, local, tribal, and territorial levels. The World Health Organization provides a variety of resources, including benchmarking tools and strategic framework to aid countries around the world in efforts to strengthen public health capacities. So when we talk about capacity and surge capacity, capacity and the related concept surge capacity doesn't have a single definition or measurement standard. However, key components typically agreed upon are referred to as the 4S of staff, stuff, structure, and systems. Staff is the personnel needed to manage an event. Stuff refers to the necessary supplies and equipment. Structure would refer to the facilities and facilities that one would work in, and systems are the policies and procedures that sort of guide what we do. Effective preparedness plans must consider the level of capacity required to meet the needs of the specific event in a given setting. Several areas of capacity must be considered: conventional, contingency, and crisis. When the needs of the event can be met with the amount of staff, supplies, and space consistent with daily institutional operations, conventional capacity is used. An example of this is when a mass casualty incident triggers activation of institutional emergency operations. When the demand for staff, supplies, and space needed to treat patients exceeds what is available for daily institutional operations, but has limited or no impact on the institution's typical patient care practice, contingency capacity is used. Contingency practices can be used on a temporary basis during a major event or in a sustained fashion when incident demands outpace community resources. When space, staff, and supplies have been adapted to provide sufficient care during a catastrophic disaster, but are inconsistent with usual standards of care, crisis capacity is being used. This occurs when the event is severe enough that standards of care must be adapted to provide the best care possible to patients given the circumstances and resources available. Broad community engagement during the planning cycle is crucial and entails more than message delivery on the part of disaster planners. It requires listening and responding to community needs, connecting with segments of the community that are harder to access, implementing community input into decision-making, and ensuring meaningful roles for the community during disaster response phase. Various communication approaches include strategic emergency risk communication, crisis communication, and crisis emergency risk communication. Each type of communication requires an understanding of the community with consideration given to all segments of the community, including their unique structures, cultures, and lifestyles. The specific approach to planned communication ultimately will rely on several factors, including the availability and quality of information, time frame in which decisions must be made, and potential impact of decisions. And nurses are critical at each phase of the disaster continuum and in each style of communication based on the needs and the risk presented. So a crucial element in this disaster cycle is resilience, which the United Nations International Strategy for Disaster Risk Reduction, or UNISDR, defines as the ability of a system, community, or society exposed to a hazard to resist, absorb, accommodate to, and recover from the effects of a hazard in a timely and efficient manner, including through the preservation and restoration of the essential basic structures and functions. Members of resilient communities play significant roles when rebuilding after disaster through collaboration and problem solving with others, and through a network of adaptive capacities and resources such as economic development, social capital, information, and communication. Development of such resources requires engagement of a broad range of stakeholders over time, because no single entity can preserve or restore community systems after disaster. And successful relationships are not likely to be built on the day of a disaster. You have to do them beforehand. And again, nurses are critical in this. When nurses know the community well, they are ideally positioned to facilitate community partner collaboration through previously established connections to community health-related networks and resources vital to developing emergency preparedness plans and policies. Effective disaster plans consider risk from multiple likely hazards, as well as local context and resources. Thus, it is crucial for nurses to develop a thorough understanding of the community's disaster risk, as well as ongoing awareness of resources to promote resilience in the community. As resilience becomes better understood, nurses can serve as champions for dual purpose opportunities that strengthen the community against future hazardous events, while also enhancing general community health and well-being. When such activities take place, they should also address the needs of populations within the community that face particular challenges during disaster recovery, including economically, physically, and age vulnerable individuals. Nurses can play a key role in increasing public sensitivity to such issues and in promoting interprofessional collaboration among multiple entities, including public health departments, emergency management departments, healthcare organization, and community faith-based organizations, or CFBOs. You'll find that emergency preparedness and response, emergency management, there are a ton of acronyms. So I apologize if you're getting a lot of acronyms that I have not defined, but please let me know. Anyway, to protect the community members and ensure that their unique perspectives on disaster resilience and preparedness can be addressed. This is another one of those issues where it's not simply a top-down theme where, you know, we come in and like Mighty Mouse, we save the day. The communities must have voice in what their needs are and what a culturally appropriate emergency preparedness and response looks like. Vulnerable populations within the community must be clearly identified through analysis of individual and household determinants, community characteristics, and community infrastructure. To connect effectively with members of the vulnerable populations, it may be useful to collaborate with NGOs or non-governmental organizations that routinely interact with them, such as community centers, home health agencies, senior centers, mobile meal services, and CFBOs. Such entities often effectively buffer against health disparities, providing information, supplies, direct services, and access to diverse community populations. They can also be highly effective partners in promoting health and disaster risk reduction because of their familiarity with the community's culture and resources, ability to communicate effectively with their constituents, and a commitment to engage in community dialogue, disaster planning, and decision making and action within that community. So I've talked a lot about professional preparedness. I will give more resources for educating nurses to educate, or actually any healthcare professional to educate themselves on professional emergency preparedness. But I really think it's important to talk about personal emergency preparedness. And again, the household emergency preparedness instrument, and I think I was remiss in not mentioning the name, but that was the study that I discussed, where it's the only empiric instrument where we gathered what preparedness looks like, personal preparedness looks like, and the one that's published and that we've utilized in several pilot studies. But overall, personal emergency preparedness involves being ready for emergencies wherever nurses and other people frequently spend their time. This might include one's place of employment, home, car, or anywhere else frequented. The U.S. Ready campaign prescribes 4 steps to personal emergency preparedness, and I think they're applicable whether you're using our empiric instrument or if you're just utilizing the ready.gov website. But they are: be informed, make a plan, build a kit, and get involved. These tenets for personal emergency preparedness emphasize the need to know what risks exist locally to facilitate an understanding of what might need to be done before, during, and after emergency. As stated earlier, we have to know how to obtain information during emergencies. Awareness of how emergency alerts are delivered locally in your area is critical to staying informed. As some governments use multiple delivery systems like text, radio, internet, and television to inform the public. Nurses also must understand the local risks and hazards of the area in which they live, so they can plan appropriate measures. Having an emergency supply kit facilitates the ability to quickly evacuate, shelter in place, depending on the nature of the emergency or disaster. Planning family resources to disruptions in resources, or family responses to disruptions in routines is also important. The dynamic within and needs of every family are different and require variations in the plans made and contents of emergency supply kit. For example, if you have kids of various ages, maybe they drive or don't, but they're in different areas. If you had an emergency, you need to plan ahead and say, okay, we're going to meet at this place. But you can't do that when an emergency is happening. You have to have done that ahead of time. If you have someone in the family that has, diabetes or something like that, you have to have medications in a kit so that if you evacuate, you're not in need, or you don't end up in a crisis in the hospital because the blood sugar for the person with diabetes is out of control. So all of those things, the nuances within each family, require individual consideration. I will discuss the contents of supply kits in greater detail momentarily. The 4th tenet of the U.S. Ready.gov campaign is to get involved before emergencies happen. And again, we talk about communication, we talk about understanding the needs of a particular community and getting to know the members of the community. That all requires nurses to get involved well in advance of a disaster. This tenet involves the entire community's participation, working together to make communities safer and more resilient, and it's integral to systems preparedness. Nurses can get involved by volunteering at work, where they can practice essential skills, or volunteering in the community to support response efforts. And what that might look like is volunteering for medical reserve corps in your area or the American Red Cross so that you can work in shelters after a disaster. But I personally emphasize not only the response, but the preparedness. And I'll talk more about why in just a moment. Disaster kits are very individualized, though there are some themes that run through what each disaster kit should have in it. And some of them are pictured here. One would want to tailor disaster supply kit based on likely risks or hazards. Plan for the most likely hazard in your area, whether it's a fire, a flood, an earthquake, or some other hazard. Individuals should speak with emergency preparedness experts and other leaders in their community to learn what risks might exist in their community and how best to prepare for them. The added benefit of talking to emergency management experts in your area is that you get to know them and you build that link, and we get that seat at the table that allows us a venue to really lend our unique expertise to people that could benefit from that expertise and planning. It is also prudent to prepare for risks that might exist at or near your place of work, as the risks at places of employment might be different than those encountered in the communities that you live in. However, the importance of emergency supply kits and the supplies in it shouldn't be emphasized, as this is an important component of preparedness and a foundational recommendation for emergency preparedness. Emergency supply kits typically include food and water for each person in the home to sustain them for the recommended period of time. I don't specify a recommended period of time because depending on where you look, it's 3 days. If you look at American Red Cross and ready.gov, it's typically 3 days. If you look at our empiric study, it's more like a week. So it's 7 days. In addition, emergency supply kits should contain money, flashlights, or in other countries, be cognizant of the fact that they call flashlights torches, candles, batteries, first aid supplies, hygiene items, and other supplies indicated by risk assessment of the area or recommended by government. Families should know how much food, water, and supplies, including medical supplies, are needed for all family members to sustain themselves for the recommended period of time. So this would just mean you would look at the recommended period of time, multiply that by the number of family members, multiply that by the number of days recommended. And you can see that this could be very expensive, and why I talk about social justice in emergency preparedness, and not just support and subsidization of response measures equally across populations, but instead equitably. Because these response measures can become very expensive, other people may need more assistance than those with more resources. Another thing to consider is if families have infants, they need to consider food, infant food, baby formula, and diapers. So those families that are caring for aging parents will need to consider the parents' medications, a list of physicians, a copy of, let's say someone has dialysis, what kind of dialysate do they need, that kind of, so you would want to make copies of those kinds of things so that you have them in your emergency kit should you have to evacuate. That would be very necessary when you get to wherever your evacuation point is. A specialized equipment, if you have a nebulizer or an oxygen machine, you would need to know what equipment, what settings would the equipment have, and other possible needs that those who have special medical needs or access and functional needs would need in their supply kit. Finally, we cannot forget our pets. Pet preparedness is very important. We need adequate food and medicine for pets. Interestingly, many people don't go to shelters because shelters may say that they don't accept pets. So now we have increased risk of people who will stay in their home instead of going to a shelter. Or even one thing that was very interesting in COVID, people couldn't stay in their homes during flooding. And I think that flooding was in Michigan, but they actually sheltered in their car because shelters wouldn't accept pets. So you can see why pet preparedness is actually really important. Even if you're not a pet lover, when we talk to clients, we need to consider that. Being prepared for emergencies is not simply purchasing a list of recommended items. Although items to maintain health while nurses, clients, and their families either evacuate or shelter in place based on the recommendations for the specific hazard, imminent threat are important. Members of a community, including nurses, must also be aware of resources in their area. Preparedness plans should include a plan for communicating with family members after a disaster, an evacuation plan that all members of the family are aware of, a plan to shelter in place if need be, and a way to receive emergency alerts and communications. In one study that I did, we asked, do you have an evacuation plan? And people would say, yes, I have an evacuation plan. Well, another question was, is every member of your family aware of your evacuation plan? And overwhelmingly, the answer is no. And so if you have an evacuation plan that people aren't aware of, you don't have an evacuation plan. Community members, including nurses, should develop relationships with other members of the community, as frequently it is the community members themselves who provide assistance to one another after an emergency until further aid can arrive. Knowledge of where local emergency shelters are typically located in the community is also important. Again, speaking with emergency management professionals and other local community leaders can increase knowledge of recommendations and community resources. So this slide is a little bit small because there are a lot of resources. So I want you to know, if you are interested in these resources, I can put the URLs in a chat, or I can put my email in a chat and send you the article that contains these resources. If you're like me, you have a ton going on and you may not want to read through the entire article. So I'm happy to support you in your quest to become more educated on disaster response, preparedness and response topics. I'm happy to support you however you like. So if you want this to be put in the chat, please don't forget, and I'll copy it and put the URLs in the chat. But nurses are often at the front lines of disaster response, providing care to populations affected by disasters and emergencies, often at great risk to personal health. Events in response to the COVID-19 pandemic highlight the importance of the important role nurses all over the world play in disaster response, as well as the personal risks they encounter. Healthcare leaders assume that nurses will report to work after a disaster, but evidence suggests that the number of nurses who will show up after a disaster is related to the type of disaster and, importantly, their knowledge of the disaster type. And remember that I said that nursing knowledge did not improve in the 15 years that this knowledge has been measured. Nurses must endeavor to seek education to become competent in each type of the International Council of Nurses Disaster Nursing and Competency domain. Education related to disasters, whether part of a formal degree, program, certificate, or continuing education, is essential to nurses becoming professionally prepared for disasters and emergency events. Education is most effective if it addresses how to work as a part of a multidisciplinary team with licensed personnel from other professions and unlicensed personnel. Although just-in-time training, and you'll see this abbreviated, I know I've already mentioned how we love acronyms in emergency management, preparedness and response, but just-in-time training is abbreviated JIT. So although JIT training may be necessary to respond to an immediate event to enhance surge capacity, a more systematic approach to continuing education beyond mandatory requirements and ongoing participation in disaster education, is more likely to enhance a nurse's confidence in being able to respond and perform effectively in a disaster. I did provide the table to provide several resources and examples of current training that nurses can access with a brief description of those resources. However, nurses should also seek information on locally delivered courses and simulations to further their education in disaster nursing competencies. Because disasters comprise both natural and human-made occurrences that can happen at any minute and location, Nurses must be aware of the current social, political, and climatological events as they evolve around them, regardless of their practice area. Nurses should maintain current licensure and practice certification and other knowledge, skills, and abilities required in their practice area at all times in advance of increased needs created by disasters or emergencies. Nurses in all practice areas should be competent in surveying for communicable diseases and the implications they might have for a particular client demographics. For example, pathogens may be more dangerous to one age group than another, or may be more dangerous to people who have underlying conditions. Nurses in the community are well positioned to educate more vulnerable clients about preventive measures, potentially preventing a hospital admission. It is important that all nurses understand the nuances of communicable diseases and other type of disasters and be prepared to respond to them using the appropriate level of PPE, but also to facilitate an understanding of which clients are most at risk. So kind of putting everything together and connecting the proverbial dots, current research indicates that nurses report to work after a disaster because they have a perceived duty to care, a belief that it is morally the right thing to do, and because of ethical imperatives. However, in responding to a disaster, nurses may find themselves balancing competing demands, including obligations they have to patients, their clients, themselves, and their family, potentially affecting their perceived duty to care. There is evidence, and one of the reasons why it is so important to differentiate between personal and professional preparedness, there's evidence that nurses who are more personally prepared for a disaster had a higher level of perceived duty to care, and that personal preparedness also affects the number of nurses indicating that they would report to work after a disaster. And this has been replicated in several studies. This demonstrates the interconnectedness of personal and professional disaster preparedness. These links between personal and professional preparedness for emergencies underscores the importance of ensuring that nurses are personally prepared for emergencies so they're able to report to work, and professionally prepared so they are competent to do so. As such, it is imperative that nurses follow all personal preparedness guidelines as described to ensure adequate capacity to provide care for clients after a disaster. Nurses must endeavor to facilitate personal emergency preparedness in their clients. What's really interesting to me is, and this is an anecdote that I have not published on yet, but we look at home health agencies, and they have great opportunity, and they actually do have guidelines to instruct their clients in the home on what emergency preparedness looks like. But there is no consistent description of what that care plan might be, what the nurses talk about with their clients, and they're not required to report to Joint Commission the contents of that plan, only that they have a plan. So another shout out to budding nurse researchers. That's another area that some people have begun working on, but it is an area of need. But nurses should provide education on basic emergency preparedness kits as outlined on the previous slide as a part of their normal education practices with their clients. If you're in acute care and you're giving discharge instructions, I mean, you can look at it like a client who's had a stroke. You start educating that client right on in admission. And so you're not like rushing and giving too much information that a client can't absorb right at discharge. So you can talk to them about it a little bit at a time while they're inpatient. So I guess what I'm saying is there's a place for nurses to provide education on emergency preparedness and response to vulnerable clients long before there's a disaster, but in many scenarios, regardless of where the nurse works. Nurses must alter preparedness education for clients or their caregivers to include any chronic disease, any access or functional needs, or any vulnerability clients might have. Mounting evidence supports that emergency preparedness education provided by healthcare professionals significantly increases preparedness levels among these vulnerable populations. And healthcare professionals doesn't just mean physicians. It can be physicians, nurses, nurse practitioners, occupational therapists. It can be members of health care professionals as they are seen as trustworthy. Theoretically, and now I'm hearkening back to the Community Resiliency Task Force framework that I had put up earlier, but theoretically improved preparedness prior to a disaster will facilitate greater resilience after a disaster, though this has not been tested. It's very difficult to test emergency preparedness and response theories in a disaster because that's not the time, to set up a study. So we do a lot of theorizing in disaster research. So several populations require specific consideration in disaster plans. Although the following examples do not constitute an exhaustive list, populations requiring specific consideration from anyone with a chronic disease, anyone with access and functional needs, children, elderly persons, pregnant women, people with mental health illnesses, those who are cognitively impaired, and those with low health literacy. Caregiver education should always be included. And now I would like to, I'd like everyone to consider these questions and have a little bit of a Q&A. I'd like to talk about what your thoughts are on how you as a nurse in your working environment might work in any phase of preparedness, mitigation, or disaster response. What might that look like for you?
Good afternoon. My name is Laveda Owens White. I'm a faith community nurse, and I practice in the faith-based setting and providing information to congregations through a newsletter, particularly during September when it is Disaster Preparedness Month, as well as when we have our monthly health observances, providing information to civic associations, neighborhood planning councils, at their meetings. As a matter of fact, we had this discussion last night with a CERT team from Florida, providing information to our national NAACP around disaster preparedness, and reiterated much of what you were saying. So it is an ongoing process. I have done 2 CERT trainings in the neighborhood, need to do another. It's been a while. I'm grateful for this this forum today because it reminds me of things that I need to do.
Well, I think you have an absolute amazing opportunity, and I'm so grateful for the work that you do in the community. And that's exactly, every opportunity to work with the population provides unique access. So thank you for the work that you're doing. In the interest of time, I know we're probably already over, and how much time do I have?
We are over time, but if you wanted to answer one more question.
Okay. Does anyone, I'll leave this open. If anybody would like to comment on items 2, 3, or 4, I don't know. I think I'd like to, can anybody talk about how they see themselves impacting vulnerable clients on preparedness measures?
Do you want me to? I think the part of your presentation about the healthcare provider's impact on disaster preparedness is mostly about just talking about them. We've seen that on a few studies, and it was extremely exciting to see that. We saw that during the our household emergency preparedness instrument development study even there. And now I'm sure to add that as a predictor variable on future studies, because I think that's so powerful. Just one of us as a nurse saying, you know, disasters pose a risk and there's something you can do about it. And here's a paper on what you could do. Could make a difference. You know, it could actually save someone's life. So I think that's the biggest takeaway for me.
Judy, did you have a comment?
Oh, I just was going to say, in our neighborhood, we have such a diverse ethnic group, and English as a second language and all of that. That I think you really have to know who the players are, and just the support for each of the folks around, and be able to. I liked what you said about collaborating with different groups. That would be all across different disciplines, besides medical, of course.
And those faith-based organizations, communities, and churches have huge impacts on the communities that they serve. So I don't want Liz and Lisa to get too frustrated with me. I'm sorry that we went over. I apologize. But I do hope that you guys found the presentation useful. And if anyone has any, let's see. I'm going to give my email in the chat. And if you'd like any further information, I won't take up any more time, but please feel free to email me and I'll send you whatever you need.
Thank you, Dr. McNeil. That was really interesting. And I wish we had more time to spend with you, but I learned a lot. So I appreciate your time with us here today.
Of course.
Thank you. We will be taking a break from our research working group until September. So there will be no summer sessions. This was the big end of year event. So thank you so much. And we'll be posting your presentation on our website for future viewing.
Thank you.
Appreciate y'all being here.
Bye-bye. Thank you.
Mhm.